Okay, hello everybody. I'm really happy to welcome you all to the International Collaboration Conference on Population Health and Wellbeing. I'm very proud that we have a very exciting program with speakers from 8 different countries. We have poster presentations and attendees from more than 20 different countries over the next 2 days. I'd like to take this opportunity to just explain a little bit about the program and the intention of the conference. We have 3 talks today from our invited speakers about global cardiometabolic patterns, about the 100 million Brazilian cohort, and about the medical administrative data sets in France, really to share the expertise, the data sets, and encourage collaborations. On the side, there's a chat button. Please put your questions that you'd like to ask in the question box as the speakers talk, and then we'll go back at the end to talk to them as a panel after all the talks, and we'll put your questions to them. We're then going to move to our workshops where we have talks about the chronic conditions theme and on natural experiments. And we'd like to ask you where you feel we should be prioritizing as a group in terms of developing collaborations and sharing expertise and skills. So I hope you'll join me at the end then to have a discussion of what you feel we as a collaborative group should be doing to build collaborations in this field. We live in a really rapidly changing world at the minute, and hopefully this can give us the opportunity to learn from each other, to replicate findings from one area into other places, to be able to work together on identifying perhaps rare events that need larger sample sizes. So you may have already joined. We have a web called the Crowd site, which if you haven't already joined, maybe you'd join. And it's so that we can continue to work after the conference to work together. Where if you go on there, there are grant opportunities from the funders' websites or on the Crowd site. And if those are of interest to people, and if you know of opportunities that we should be putting on there, put them on the Crowd site or send them to us and we'll put them up there. If you know of conferences or meetings that you feel others would enjoy and benefit from, if you know of job opportunities, please put them on the Crowd site. Send them to us, we'll upload them. So really, this conference really is to be able to work as a collaborative group to support each other, hopefully, in improving population health and well-being, really to help with skills development, career opportunities for researchers in this field around the globe. So again, I'd like to say thank you very much for joining us today. I really hope you enjoy today's meeting. And I'd like to hand over now to Ronan, who's going to be chairing the plenary session. And just to remind you to put any questions you have for our speakers in the chat box as they speak. Thanks very much and talk to you soon.
Yes, hello. Prynhawn, or good afternoon, as we say in Welsh, welcome to this conference. My role really is just to briefly introduce the 3 keynote speakers that we have this afternoon. So it's my great pleasure to start this. The first speaker is Majid Azati, who's Professor of Global Health at Imperial College London. Majid and his research group have conducted field studies on air pollution in Kenya, Ghana, the Gambia and China. He led the World Health Organization's comparative risk assessment study. This was the first consistent global analysis of behavioral, environmental, nutritional, psychosocial, metabolic risk factors. And it formed the scientific core of the World Health Report back in 2002, reducing risks, promoting health and life. Majid leads the non-communicable disease risk factor collaboration and the Countdown 2030 of the same name. He's involved in worldwide scientific collaborations which aim to strengthen the evidence base for a more effective NCD prevention and management. And he also leads the Pathways to Equitable Healthy Cities, a global partnership that aims to improve population health, enhance health equity, and ensure environmental sustainability in cities around the world. And Majid is a fellow of the UK Academy of Medical Sciences. So without any further ado, let's all listen to Majid.
Thank you, Ronan, for the introduction, but especially thanks to Sinead and colleagues for organizing the meeting. It's a really great idea, and I hope it does continue. Of course, thanks for having me. So, given the purpose of the meeting, I'll talk about our work on non-communicable diseases around the world, but I'll talk about it in some sense from a perspective of a platform. I'll actually show results, but the focus is as much on the platform as it is on the specific results. The NCD risk factor collaboration, non-communicable disease risk factor collaboration, it's a network, it's a global network of scientists. There are well over 1,500 of us now, or over 1,500 of us. And we work closely with the WHO. WHO is formally involved in this, and they use the results as their official statistics. We have been active for over 10 years. We bring together population-based data on cardiometabolic risk factors and increasingly on other NCDs. We have brought together over 3,000 studies, over 3,400 studies that have done measurements of certain traits on over 200 million people in virtually every country in the world. There are a few countries where we don't have data, and these data go back to the 1960s. So in fact, a core interest is what's happening over time and how are things changing. And there is a whole team of people, largely in London, but also in Geneva and elsewhere, that really their work, and it's actually really hard work, and is to actually screen all the studies, make sure that they are representative of populations, and they have done high quality measurement. So when you are dealing with data that go over tens of countries and decades of time, the whole issue of what you're using becomes a question, and people are doing this. And a lot of our materials are available on a website that I have mentioned there. I actually invite you to go there and look. There is visualizations you can work with, and results to download. And many people actually use the outputs of the study for papers. There have been, I think by now, hundreds of papers written just using the outputs of the work. When you are trying to give a picture of what's happening to certain traits and conditions over decades of time in a couple of hundred countries, there are all kinds of challenges we run into. It's obviously impossible to do it by primary data collection. We can't collect data about the past, and the amount of resources that would go into getting these data would be fundamentally impossible for any research entity to do. So we run into situations that data, and I've shown the graphs that are at the bottom are showing examples of this. Data can be sparse. They can be sparse geographically and over time. And you can see in here on hypertension, Burkina Faso in the Middle Ages had only one national study over these few decades we are looking at, and so on and so on. And then on the other extreme of this is Japan, a country that has got a nationally representative survey of its population every single year since the 1960s. There are data that are sparse in age, and especially in older ages. Within the same country, even when data are national, they have a lot of variability. So if you can look at the panel that has China in it, you can see that the blue points, which are national studies, actually done by the same agency in the same year, but different divisions of the same agency, they vary. And I'll come to some examples of this from the UK later in the talk. Some studies may be representative of a population, but may just be a region of the country or communities. We use these, but we account, as I'll come to it, we account for the fact that they are not, they don't cover the entire country. Some studies may be only urban or rural, and we might be dealing with patterns over time or over age that are non-linear, and we have to worry about this. I'm going to show one slide only that sort of puts in words our methodological work. So the whole component of the collaboration is actually a methodological component. Colleagues in statistics and increasingly statistical machine learning that are developing methodology to be able to synthesize all of these data. to bring together data across different countries, years, and age groups, and look for similarities within the same country over time and across countries, within regions and across regions, to try to make estimates for every country, every year, and every age group based on the totality of data, but at the same time account for the uncertainty that arises from data either being missing or highly variable. And for statisticians in you, both of those are relevant. The methodology tries to take into account of nonlinearities in over time and over age. And when data are not national, it tries to account for either systematic or random differences that arise. So again, a whole sort of methodological machinery that is going together with the data, but really embedded in the data to try to use it as well as possible. So I've shown some examples here, and this is from the UK. So blue points are national, the yellow ones are subnational, and the pink ones are covering particular communities. And you can see that even in the UK, a country with a well-funded survey program, or multiple well-funded survey programs, in fact, there is a fair amount of variability in data, and the thick lines and the gray areas are showing the fits to these and what's happening to hypertension over time. What have we been doing with these data? So far, we have been looking at trends in a number of factors, generally individually: height, body mass index, blood pressure, lipids, and lipid profiles, and diabetes. And we have started recently to look at some population subgroups, so far focusing on urban and rural place of residence. There is a lot of interest and a lot of actually assumptions about how cities and rural areas may differ, and we wanted to bring empiricism to this. And we have been looking at treatment coverage and control of risk factors because health systems actually influence population health, and we wanted to start asking some of those questions. The results, as would with any other academic work, have published a fair amount, and they tend to get attention, and they are actually used again widely through generally international organizations, but also national agencies. And an example of that is actually the recent work we did on hypertension. There were many countries, many industrialized countries, and I'll come to that, places like Canada and South Korea that are completely outperforming the UK in hypertension detection and treatment. And a question has come up in the UK that what can we learn from Canada in how they diagnose and treat hypertension and cover so much more of it. So international and national influence. Now, I'm going to go through some of the results just to give a flavor of the sort of things that could come from these data. The results, I tend to think are interesting on its own, but I also want to, again, bring out the sort of results that come when you bring this quantity of, and hopefully of high quality data together and synthesize across data. So not a surprise, but with a lot of detail, rise in obesity in the world, and this is sort of the most summary picture. And especially at the high ends, at the severe levels of obesity and morbid obesity, and actually a slower decline in undernutrition happening in the world. What this graph is showing, so each of these lines is one country, and it's the scale is going from 1975 to 2016, which is when these estimates were made, and this visualization on our website. So you can again go and look at them, and it's showing how each country is changing. It's colored by the region of it, and as you can see, there is different rates at which countries are obesity is going up, and the fastest rate has been in many middle-income countries. If you pay attention to the green and the red points, especially. So the green ones are much of Latin America and Caribbean, and the red ones are Middle East, North Africa, but also some of the other middle-income regions and increasingly emerging economies have seen some of the fastest increase in obesity, in BMI in this case, but you have also told the sort of story by categories. Now, a very strong belief in global health had been that this is all about people living in cities. And again, we had the data to be able to probe this question in detail. So what these lines are showing, each line again is a country, they're showing the difference between urban and rural areas. So it's the larger the number, the higher body mass index in cities. And as you can see, many of these lines are actually moving to the left. So the difference between urban and rural areas is becoming smaller over time. This is in the case of adults. There are some places it's becoming larger. And in fact, in many high-income countries, it's actually negative. So higher obesity in rural areas than in cities. For those of you familiar with UK, again, UK is a bit of an exception in its high-income countries due to patterns of urban poverty in this country. But many places these lines are going to the left. So there's actually a convergence. This is the adult story. I won't say anything on the adolescents because that's actually work that's being completed right now. But the adolescent story brings some other complexities over to what happens to cities versus rural areas. This is again what I mentioned, that the brown points are brown and orange, showing a higher urban BMI, and the blue and purple are showing a lower urban BMI. And we can see that in many European countries, BMI, body mass index, is actually lower in cities than in rural areas. And just to divert for a moment to go out of our own work, and people have been looking at this in many ways for decades, that there is some things about cities that actually allow them to have, in many ways, better nutrition. The paper on the left is a great paper from 1970s that had looked at various forms of malnutrition and how cities were doing better. And the one on the right is an American paper that a group of researchers in agriculture started looking at availability of good food. So rather than looking at the bad stuff, they looked at the good stuff, things that are generally fresh and diverse foods. And they found that, at least in the American context, you can actually do better at those in cities, and you can actually get more fresh fruits and more fresh products in cities than you can in rural areas. So together with body mass index in the case of children and adolescents, we started looking at height. So each of these arrows is a country. The x-axis, the horizontal axis, is their height. So if things go to the right, that's a good thing, because children and adolescents are growing taller over time in subsequent cohorts. And if it's going up, it's a bad thing for most parts, because they're becoming more overweight. There may have been some underweight that are catching up, but generally becoming more overweight. And looking at these, it actually showed that this is actually a more complex picture than we see just out of the obesity. So many places, and the green ones being Latin America, and again, some of the other middle-income regions here, middle-income and increasingly emerging economies, yes, obesity going up, but actually height is going up really fast. And from a public health perspective, there is actually not trade-offs, but they're getting some of the good things, increasing height, and some of the bad things, increasing BMI. And sub-Saharan Africa has experienced a large increasing BMI, but actually over at least these decades, not much of an increase in height. And arguably in some countries, especially for boys, there was a bit of a decline in height. And again, I'll save the sort of potential reasons for that for our discussion of why that may have been happening. There is a literature that has looked at why this may have been happening. So body mass index going up, it is a risk factor for diabetes. Is diabetes tracking it? And what we found is that actually the diabetes story has its own complexity. So in many high-income regions, although diabetes is going up in a crude sense, so accounting, a lot of that is due to aging of the population. And when you look at it in an age standardized way, it hasn't changed much. You can see it in the upper part in the blue parts of those graphs, whereas it's going up really fast in some of the middle-income regions. So if you get the purple and some of the greens and some of the reds, and on the right-hand side, you can see this as a scatter plot that's showing no change, increase and doubling. And a lot of the no increase are blue points. That's Europe largely, and a lot of doubling or more than doubling are the purple and the greens and the red points. We actually started probing the literature when we found that result first, and realized that when people have done repeated studies in the same communities, and I've put here examples from one Swedish and one German study, they've actually found similar results in generally the northern part of Europe, that virtually all of the increase in diabetes is due to aging. and in any age group in certain countries prevalence, and these are prevalences that are based on random samples of the population, don't seem to have changed. And again, this is opening up a whole set of questions for us that why, I mean, although holding everything else constant, increasing BMI should be associated with increasing diabetes. What else is changing that's actually showing that is almost decoupling the BMI and diabetes trends? Cholesterol, it's actually gone in some ways even farther than diabetes. So in much of the wealthy countries, and increasingly in the southern tip of Latin America, cholesterol has actually been coming down, starting from Northern Europe and UK and New Zealand and Australia, but going elsewhere. Whereas in especially Southeast Asia and then parts of Sub-Saharan Africa, cholesterol levels, and this is non-HDL, so this is the bad cholesterol, has been going up. So it started much higher in Europe, but it has gone in completely opposite directions, so that by now the highest lipid levels in the world, highest bad lipid levels, non-HDL, are actually in Southeast Asia. Places like Malaysia have got some of the highest levels of non-HDL cholesterol that in the world today. And again, when you look at some of the literature on components of food and diet, palm oil and so on, and then changes in both food but also treatment in Europe, one can actually start to see why these may be happening. And finally, the blood pressure story. So again, arguably even farther than lipids. So each bubble here, and these are again on the website, and you can go and look at them. Each bubble is one country. The really large ones are China, India, and the United States. They're by the size of the population, the largest ones. And the large blue one is US, and the other ones are China and India. We can see that over time, in here it happens to be in relation to national income. Blood pressure went from a situation that it was higher in the wealthy countries at the time. So on the upper right-hand side corner, over a period of 4 decades, it has gone to the situation that it's actually noticeably higher in low and middle income countries. So a complete reversal of the pattern. Now, for those of you who are wondering, is this just treatment? Just the short answer is that it's not. So this map is showing total hypertension. On the left-hand side, it's showing level, and on the right-hand side, it's showing change. Green is good, and red is bad. And you can see that even total hypertension coming down. And again, I'll save the reasons for that, why that may be happening for the question period and discussion. That what is it what is it with wealth that actually drives down blood pressure? And again, the highest blood pressure levels in the world now tend to be in either in Eastern Europe, Central Eastern Europe, or in what would generally be called the global South, so Southeast Asia, parts of Sub-Saharan Africa, and parts of Latin America. I mentioned that we have started to work on treatment of conditions. So this graph is showing coverage of hypertension treatment. This is for all forms of hypertension, and dark blue is good, and the sort of lighter beige color is not good. And we can see that the coverage of treatment for hypertension ranges anything from sort of around 80% of people who need treatment are receiving it. South Korea and Canada happen to be the front runners for this, but also going well in some other countries, to below 10%, unfortunately, in some of the lowest income countries in Sub-Saharan Africa. And remember, these are medicines that have been tested in trials and in routine healthcare for decades now. They are extremely cheap now. They're off patent, and yet where some of the highest levels of blood pressure and hypertension are being seen in Sub-Saharan Africa, people are not receiving them, and in fact, they're not diagnosed, many of them. But the good news is that, in some sense, that's the bad news. The good news is that some of the best coverage in the world is also seen increasingly in some middle-income countries and emerging economies. So places like Turkey, Kazakhstan, Chile, and actually Costa Rica, which has one of the very highest ones in the world, through a really good health system, they have actually managed to use the knowledge and to use good programs and good health systems and increase coverage to the points that they are outperforming many European countries. And again, we are able to actually probe where in the treatment cascade or in the care continuum this leakage happens. And it turns out that the leakage for treatment and control of hypertension happens everywhere. So if you look at the places that things are going well, high-income countries, either in the Pacific or the Western countries, as well as Latin America and Caribbean, yes, some people are not being diagnosed. That's the left-hand side part of this cascade. Of those that are diagnosed, a small percentage are not treated, and there may or may not be good clinical reasons for that. I tend to think that there generally aren't, but maybe. And then many of those who are treated are not well controlled. And that means that of all of the people in every region, control of hypertension is less than 50%. Just to set a benchmark on this, in some really well done health programs, the Kaiser Permanente in the US or the Canadian hypertension program, this number would be about 2/3 or 70% control. So this is well below the benchmark. The situation is at the other extreme in Sub-Saharan Africa, South Asia, and Oceania. It's below 15%, below 20%, 15% control. So less than 1 in 5 people are getting controlled, and in fact, more than half are not even diagnosed. And the rest of the world is somewhere between them. And I mentioned there is a lot of variability within high-income countries. So this is just the raw data, no sort of putting it together, no synthesizing, from 12 high-income countries. And when you look at the black points, Canada, and the dark green one, South Korea, again, these are the 2 best performing countries. And then at the other end, look at some of the other countries like Japan and UK, somewhere in the middle, and New Zealand and some of the others, actually much lower treatment and control compared to the front runners, which happen to be Canada and South Korea in this case. I seem to have lost my advance button. Here we go. Okay. So let me bring this to a close over the next 2 or 3 slides. This is from another piece of work, but I think it sets the context for what I hope we might get to in discussion. So what this graph is showing is for a set of major non-communicable diseases. It's showing the distribution of change over time in death rates. So a negative number is good. That means death rates are going down. And what this range of these points is showing is the difference between the 10th and 90th percentile of countries. So the green points on the left are the sort of 10% best performing country in terms of decline. In many cases, it turns out to be South Korea in there. Or South Korea is actually in the 10th percentile, so doing better than the green. But a number of countries are doing really well in bringing down non-communicable diseases. And on the right-hand side, it's the 10% worst performing or 98% best performing, however you want to think about it. And we can see that there is a lot of variation. So especially for stroke and heart disease, many countries have experienced a decline over decades after accounting for age. And for other things, some of the cancers, things going up. So a lot of variation in the world in terms of how death rates have gone. And it's not just in the high-income countries that things are going well. Again, a lot of variation within high-income, but at the same time, there are a number of, especially middle-income and emerging economies, places like Turkey, Iran, until recently at least, Chile, Costa Rica, and a number of places have actually done quite well in many ways. And one of the questions is about why is this happening, and how can we learn from the best performances? And what our work is getting one level below this, looking at the risk factors and treatment. And the other part of this that's relevant is that as a result of these trends, non-communicable diseases are actually now highest in Central and Eastern Europe and parts of the global South. This is for men, where it has actually been particularly high risk in Eastern Europe, in the former Soviet Union. If it had shown the graph for women, in some sense, parts of Africa and South Asia would be even more pronounced. I wanted to show the extreme here in this case. So this is a situation that's increasingly, if not now solely, a situation of global health. And again, the attempts for our work and where it's going is trying to learn from best performance at a level below the outcome. So where we are going with this, I mentioned that so far for population subgroups, we have just started to look at rural and urban place of residence. We are going to expand that to look at other factors, but we are interested to look at a specific age group. So young adults, adults, children, adolescents, young adults, middle-aged adults, older adults, to the extent we can, and it opens up a whole set of methodological issues on comparability, looking at it for subgroups based on socioeconomic status. And how are things going for various risk factors for treatment, or to look at population subgroups based on their weight status. So what's happening to blood pressure in people with underweight, with overweight, with obesity, and we are very systematically looking at the coverage and control. Hypertension work, we have done it, and I showed it, but other things are happening. And then we are looking at patterns of multiple risks and conditions, and both at the national level. So are there countries that are doing well on a lot of things or not well? And again, I showed the sort of the decoupling of BMI and diabetes, the reversal for hypertension. Where is it putting entire countries? And then what happens to individuals? And then within this, we are hoping to expand the list of our risk factors, things like markers of kidney and liver disease, inflammation, infection, and history of major diseases. So if I could end by a moment of advertising, if there are studies that you are aware of or you hold the data on, we work as a data pooling consortium, so all of our collaborators are involved in the entire process. Please email us, and I guess for all of our enthusiastic, energetic early career researchers, we do occasionally have PhD and postdoc positions. They differ over time based on what they focus on. Email us, email me if the time is right for you. And I will just end on this slide, which is that obviously this is a data pooling collaboration, and it only exists because of our collaborators. And sometimes we're actually embarrassed how responsive people are when to requests, but I hope it's because they find the science and the impacts of it interesting. And then I mentioned this amount of data doesn't just come together because people provide it. So beyond people providing it, there is an entire team that's spending a lot of careful hours finding data, seeking data, and checking data. And we have found things about data sources that original investigators didn't know sometimes. And finally, I guess our funders, and I should mention that back in the days when at Wellcome Trust population meant actually population, the Wellcome actually funded the original formation of this, and then a number of others since then. I won't go through it, but I think those were the days that again population meant population. I'll stop now, and I look forward to any discussions that arise. Thank you again, Sinead, and thank you everybody for listening.
Well, thank you very much, Majid, for an absolutely fascinating presentation. I'm sure lots of people will have many questions which we'll put to you. We're a couple of minutes ahead of schedule, but I think we will continue now in a moment with our second speaker. So also great pleasure for me to introduce our second speaker, Mauricio Barreto, who's a professor at the Federal University of Bahia and co-founder of the Center for Data Knowledge Integration for Health, or CDAX, which is based in Salvador, Bahia, in Brazil. And that runs the 100 million Brazilian cohort, which is designed to investigate the role of social protection policies on health. And Mauricio's background is in epidemiology. His research interests in social and environmental determinants of health, health inequalities, the impact of social and health interventions on health, and integration of social and biological knowledge for causal explanations in health. And Professor Barreto is an elected fellow of the Brazilian Academy of Sciences and the World Academy of Sciences. So over to you now, Mauricio.
Oh, thank you. Thank you for the invitation to come here. Yes, thank you, Sinead, and the other group for inviting me to be in this conference. Yeah. Well, I'd like to present today an experience that is in course here in Brazil, in Salvador specifically. Yeah, and in create a data center, yeah, using the national Brazilian data, yeah, routine data, yeah, and put together and vinculate this data, aiming to produce epidemiological knowledge. Yeah, then this is my purpose is to present the logic behind the CDAX organization and to present some results, yeah, that you have been producing. Yeah. Well, the vision behind SIDAX, yeah, and behind this idea that you can use large data sets that exist in different countries, yeah, and they have improving quality in the past few years, yeah, is that yeah. This is a very valuable data. Yeah, all the routine data that's accumulated in different databases. Yeah, being healthy data, directly healthy data. Yeah, or being social and environmental data. Yeah, that can be in some way connected. Yeah, this exists in different contexts. Yeah, and the great role, yeah, that the research, yeah, need to advance is to put this data together. Yeah, this is a big challenge. Yeah, because there is a lot of ethical, legal, and technological, operational question. Yeah, to put all this data together, mainly in large countries. And Brazil is a large country with over 200 million inhabitants, then the amount of this data is very large, yeah, as I will show you. Sorry, here. Yeah. Well, this is a very powerful, as I said, very powerful data, yeah, because they have a lot of advantage. Yeah, I put here some. Yeah, is you can build you have large samples. Yeah, it's natural because this data if you collect the data all over a country like Brazil, they generated a large sample. And one of the big issues in health research nowadays is the sample. Yeah, you saw in the previous presentation the importance to put together data from different studies, yeah, to produce large data sets, yeah, to answer really important and relevant question, yeah, for and very easy to be generalized, yeah, and to be used for decisions and other purposes. Uh, you have data for the entire population, yeah, not only a sample, but you can have it for data for all the population. Yeah, and you can have your this data in some way longitudinal. Yeah, because the routine data are collected over time. Yeah, each individual inform in different moments of time about the different aspects of the life, and these are registered in a longitudinal way. Then if we put together this data, now you can keep this longitudinal structure in some way that is a very relevant aspect is in health research. The CDAX is a center now was created a few years ago, 5 years ago, yeah, and is to try to explore the potential of this data in the context of Brazil. Now you are focus on Brazil, yeah, and yeah, to try to develop technologies, to develop joint efforts of different individuals to put together this data and to use this data to produce important information and evidence about the big health problem that exists in the country. Then one concept in that, that I think is very important to stress is that if you, in general, the research data and the routine data very separated. Yeah, you have two worlds. Yeah, of the research and the practitioners that use a different set of data. In a concept that if you put together and you use the routine data to do research, now you can close the distance, among the researchers and practitioners. This is a view that you share, and I think is very much important, to explore the potential of this data to in health research. What make it CDAX possible is to access that was given them by different sources of this data are public data managed by different government agencies, and it was possible to have access to this data. This is the first things, is the quality of the data. There is any data have problems, but in general, the data, the health data, and the others data that are routinely collected have improved a lot of quality. Now they are very complete in some sense, and they can be assessed by different kind of arrangements. Is the possibility to access this data. This is a conceptual platform of CDAX. Is a structure that is in development. That have different layers and to protect, to operate this data, because this data, the original data are identified data, then need a lot of protection. Then there is a data protection layer that is very well protected against any kind. It's disconnected from internet, for example, and operating in very specific condition. And the others layers, the data curation layers that care about anonymization and the on metadata and the other things, and the data access level. Everything protected, on very high security levels, privacies, ethics, and comply now with ethical and legal standards, to use the data. There is a lot of initiatives, but I think the two major things, is to build a kind of a cohort. Cohort is very common design in the health research in general, epidemiological specifically, but health research in general. And then in CDAX was created the two cohorts. One that you call the 100 million Brazilian cohort, that is the baseline of this cohort is a data from a registrar that exists in Brazil. Everyone applying for a social protection need to complete a lot of data, a form with a lot of data. This form had been assessed for us, and is the baseline of the cohort. To have an idea, there is now in this cohort over 100, around 130 million registers, individuals participate, and to this is connected different databases, from social protection achievements, or from mortality data, birth data, hospitalization data, and then you can connect to these databases, original databases, these others layers of information over time. Then you have these which you call the 100 million cohort, or a similar structure, with birth, that you call the birth CDAX birth cohort, that have around 20 million births so far. With this, I need to call attention the legal framework. This is important thing. It is certainly a barrier. Because nowadays to work with data from different countries, different contexts, is have a lot of questions. A lot of limitation given the legal constraints. And Brazil in Europe, you have the GDPR. Now in Brazil, you have a law that is now in place, a 2 years old law that regulate all the use of this data. And it's very nice because you have in some way a clear framework on how to utilize the limits and the question. And the law created the legal framework to CDACs to operate. But I'd like to show some examples of the use of this data. And there is a lot of different purpose to use this data. It's not only one, and there is no the aim of CDAC to study a specific problem. But you are open to study and to investigate different questions. And then I'm going to show here some example. Some of my for research of CDAC will be later in some session. Other session present some results. But I'm going to present some great areas where have potential to use this data. It's a few examples. And then I think one thing important is to use the data, large set of data, to study rare event. There is a lot of public health events that are very much important, but it's not so frequent. This is a major challenge for health researchers to solve some questions. In general, we have used meta-analysis or done meta-studies like the previous one to compensate that. And here are some example of investigation that was only possible because we use this large set of data. For example, to study the effect of dengue on pregnancies, on the newborns. This is a important event while not so frequent. And this need a large sample to be investigated, or to study the incidence, the household risk on leprosy. Leprosy is yet prevalent in Brazil. Is not so frequent. It's a relatively rare event, but very important in the public health aspect. And this study show, for example, that in the household environment, there is a risk of transmission 60 times higher than in normal population. Then is a very important data to inform decision programs and things, action that are focused on leprosy control. Data to investigate social determinants of health. Social determinants are a very important aspect for us epidemiologists. And to study this in a large sample, you can study this in a country like Brazil, and studied in different contexts, how different determinants operate in different contexts. How the data is very well standardized over the country. All these data are national data that use the same standard of collection. Then you have this advantage to make comparative studies among regions, among areas, among subgroups of the population. You can stratify the population in different aspects. That is a very useful in thing. Here are two examples now of this application, one in leprosy, and another is in low birth weight. Two completely different health questions, but using the same data in some way. Another thing that you have been explored and having special interest here in our group is the impact of social protection policy on health. You have a long understanding in public health that the social determinants are very important to define the health pattern of any population. And the use of a common policy of social protection policy that have been applied in different countries in the world, developed, but nowadays a lot in developing countries, like cash transfer programs, for example, they have created a natural experiment or quasi-experimental opportunity for research to explore the links among a measure that is focused, like cash transfer, that is focused on decreasing poverty, on impact of health. Here are some example of this, be it on leprosy treatment, or in child health. There is other study come out on mental health, on maternal mortality, and others outcomes that are affected when you change the poverty situation of this population. This is a very important opportunity. Now it's an area that is growing in economics investigation, but also in public health investigation, epidemiology investigation. That is the quasi-experiment or the natural experiments that create unique opportunities to explore the impact and how changes in the population affect the health status. Then this has been a great focus on our group, and there is a lot of methodological challenge to do that, but they have been an area of exploration and advancement. That data to evaluate the impact of primary health care. Primary health care is a central focus, since the Alma-Ata meeting near 30 years ago. Primary health care is a focus on the development of the health system in our countries, in developing low and middle income countries. And to evaluate the effect of that, have been an effort of different groups of research all over the world. Here, an example of this study, a recent publication in Lancet Global Health, show the effect of primary health care on tuberculosis, using a large sample of 7.3 Brazilian to study this specific aspect. Or I study a project that is growing, that is going on evaluating great details, the impact of the primary health care on under 5 mortality. I try to explore in great details the component of the primary health care that affect the mortality. Other areas, evaluated the impact of medical intervention. For example, here a very interesting study, linking cesarean section. Cesarean is important technology, that protect the woman, the pregnant woman, in the birth process when necessary, but have been used, so far in a very not so standardized ways, or not so where there is no clear medical indication. Then in this study, you show clear now using our birth cohort, how the cesarean that Brazil have near 50-60% of the births are using cesarean. That is very high, and show very clear that when you have indication to use cesarean, the mortality up to 5 years, it was possible to study up to 5 years. There was a protection of the kidney, a decrease of mortality. When you have no indication or no clear medical indication for the cesarean, this increases the mortality risk. Then it's a very important find, that was only possible using millions of births, to study in great details and to stratify and to have sufficient data to analyze the indication or not indication of the cesarean. Well, data, there is other application. I've been going quickly to development of diagnostic tools, using artificial intelligence methods, for example, to explore new ways to improve diagnosis. This is an important application of data nowadays. As this case, that the development of diagnostic for Zika syndrome. Yeah, Zika is a very important problem in different countries in Brazil, in the other Latin Americas and Asia countries. Yeah, and but there is some problem of classification, and then explore artificial intelligence methods was possible to develop a relatively easy tool and very applicable and that can be used in small computers, yeah, to with a great chance, yeah, to classify syndrome cases or Zika syndrome cases. Yeah, data in the recent stage of COVID, yeah, data have been used to evaluate the effectiveness of COVID vaccines. Yeah, then the access of an important database that was the vaccination take in Brazil and the other databases is possible to do big studies. Yeah, to evaluate and to create a monitoring system, yeah, to keep the evaluation of COVID vaccine, yeah, over time. This is very important because vaccine, the COVID uses different vaccines, yeah. There is a problem of the waning period, yeah, the waning, the effectiveness in different age groups, because there are a lot of problems that was not solved by the trials, yeah, and need good effectiveness investigation or post commercialization investigation, yeah, to keep it inform decision regarding the use of these vaccines. And here are some example now of the use of data, Brazilian data. This on Brazil. This compare now you are having worked with a Scotch group, yeah, compare the weighing of the Shadox vaccines in Brazil and in Scotland, yeah, and this one to study the coronavac, that's another vaccine, yeah, and the role of the booster on the coronavac on the after the second dose. The modeling, yeah, is another area that we use this data to model the epidemic. Yeah, there is a lot of examples. Yeah, it is being used worldwide. Here are some example done by groups related to CDAX. Yeah, explore different aspects, yeah, of the dynamic of the epidemics. To conclude, yeah, I think is to only is also to give a flavor, yeah, that to organize a health data center like this one is a huge challenge, yeah, but challenge in different ways, yeah, methodological, yeah, all the question related to data, the use of data and the use of data, privacy, yeah, legal question, yeah, operational question. The dimension of the data is very large. It's created the specific question in data analysis, yeah. But you have been, by the other side, rewarding and show the importance of the use of the routine data in a low and mid-income country context, yeah. And it's possible with this data produce sound scientific knowledge around the critical health issues, yeah, with a high level of generalizability and applicability. And then I have the great potential of the use of this data and show also the possibility to do federated analysis, yeah, as for example, Scotch example to use data from Brazil and for Scotland, that all the potential to use and to do federated analysis to fulfill or to answer a question that is beyond or not specific of a specific country. Then this I'd like to thanks again is and if anyone have a question, it will be a pleasure to ask, to answer the question. Thank you very much.
Oh, thank you very much, Mauricio. That was an absolutely fascinating presentation. You nicely went through all of the, well, so many different uses that data like that can be put to, and it's superb to see. So we're just now going to move on to our final speaker, and I'd like to introduce Professor Canton. who's led the Biostatistics and Medical Information Unit of Dijon Teaching Hospital since 1998. So she's been in this field for a long time. She's a member of the Centre for Epidemiology and Population Health INSERM Paris team and the INSERM CIC Clinical Investigation Centre. And her unit specialises in the statistical analysis of data contained in major medical databases in the field of public health. The team are responsible also for the collection, coding and statistical analysis of the Hospital Medical Information System Programme, PMSI. The research activities include the development, comparison and application of statistical methods and prognostic methods in particular to meet the challenges associated with the exploitation of health data. And our team were one of the first to obtain authorization to access data from the SNDS database, which is a nationwide centralized administrative database of all health services for pharmacovigilance. She's a wide range of international collaborative studies underway. She's also developed new methods in anonymous identification and linkage, which are now used in France and I'm sure are used in many other parts of the world. She's been the president of the College of French Biostatistics and Medical Informatics Teachers, the general secretary of the Association of French-speaking Epidemiologists, and chair of the Educational Committee of the International Society of Clinical Biostatistics. And currently she's the honorary editor-in-chief of the Healthcare Management Economics Journal. So, Professor Canton, looking forward very much to your presentation.
So, thank you, Ronan, for this very nice introduction. I would like to thank you and Sinead for inviting me to this very impressive collaborative meeting. It is a great pleasure for me to present today some studies from the French Medico-Administrative Database. So, during this presentation, I will firstly give you some information about the French National Health Insurance Information System. I will then show you some examples of research applications in which I was involved in collaboration with physicians. In fact, I organized medico-administrative data collection for many years in my medical center, and I know that physicians spend a lot of time collecting this data. My main motivation was at first to help them use this data for research. So, as you can see, in France, health insurance organizations collect reimbursement claims forms. Most of these records are transferred to a national database after being rendered anonymous. As you can see on the right hand of the figure, this national database also contains hospital discharge abstracts, which are filled in for each hospital stay. More recently, information about all deaths has been included in this national database. As a consequence, all individual reimbursement claims data, both ambulatory care and hospital discharge data, are centralized and linked together. As you can see in the second bullet of this slide, this database is nearly exhaustive as it comprises data from the 3 principal health insurance schemes. And you also can see here that it contains, for 60 million patients, all their reimbursement claims and hospital discharge abstracts over a long period of time. I will now show you some examples of these collaborative research applications that were made possible thanks to this national data collection. I will first focus on general indicators and then present some more recent applications on the COVID pandemic. So, regarding epidemiological surveillance, health insurance organizations are often interested in estimations of the frequency of diseases at the national scale. As you know, national surveys are very expensive and registries can rarely cover the whole territory of the country. The National Medical Administrative Database is therefore of great value to estimate the frequency of hospital prevalent cases at the national level, in particular for rare diseases. So you can see in this figure on the right hand that we could estimate hospital prevalence for endometriosis. We could also use this methodology for other applications such as male breast cancer and childhood abuse. We have also made many applications on mortality. Initially, this National Medical Administrative Database allowed us to estimate only hospital mortality. Today, we can also estimate overall mortality. So you can see in these figures in hospital stroke mortality. Clusters were constituted according to mortality rates standardized for age and for the professional status. This information about the population living in a given geographical area was obtained from the National Census Institute. And we have performed the same analysis on other diseases, for example, on myocardial infarction, with similar results. So in addition to the capacity of providing general indicators for epidemiological surveillance, we have also found that these medical administrative data were very useful for healthcare quality assessment. I will now show you some examples of these applications in different situations such as safety, policy evaluation, or technology assessment. Regarding vaccine safety, we were able to demonstrate that it is possible to obtain the same results as those obtained before with large cohort studies, as long as you can apply an appropriate statistical methodology, such as, for example, self-controlled case series analysis. As you can see, the second bullet point of this slide is related to drug safety. I coordinated a project about the toxicity of drugs during pregnancy, and you can see here some examples. We found that early exposure to NSAIDs during pregnancy was associated with a significantly increased risk of preterm birth. Regarding exposure to anti-TNF-alpha during pregnancy, we also found a higher risk of complications, such as infections. For policy evaluation, we compared the rates of 30-day all-cause rehospitalization in France versus the US among Medicare beneficiaries. We found that these rates were lower in France, around 15%, as you can see in the figure on the right side, than in the US, 20%, as you can see in the figure on the left side. These results were obtained for patients older than 65 years. As you can see in the second bullet point of this slide for France, we were able to use medical administrative data, eventually linked with registry data, to investigate rehospitalization risk factors for different conditions, such as cardio-neurovascular and psychiatry diseases. So I present in this slide an example of an application for technology assessment in the framework of cataract surgery. In this study, we showed the impact of injections of antibiotic into the eye during surgery in terms of post-operative infection. And we observed that the use of this injection began to increase shortly after the publication of the clinical trial, but increased more steadily after the commercialization of the recommended antibiotic. And we also observed that the incidence rate of infection, such as endophthalmitis, decreased more markedly during the commercialization period. So regarding COVID-19 in France, we were first able to use hospital data to study risk factors for severity. We also investigated the impact of the pandemic on the management of patients hospitalized for other pathologies. So you can see that first, we performed a comparison of some characteristics of patients hospitalized for COVID and for seasonal influenza, but also in terms of morbidity and mortality. More specifically, we investigated the risk of pulmonary embolism in patients hospitalized for COVID. We also studied risk factors for admission to ICU or for death in COVID patients suffering from respiratory diseases or cancers. So I will now detail the results related to pulmonary embolism. As you can see in this figure, the number of non-COVID patients hospitalized with pulmonary embolism was nearly the same in 2020, as shown by the green line, compared with 2019, blue line. Well, in fact, the number was a bit higher. And if we zoom on patients hospitalized for COVID-19, so you can see in the red curve for 2020, patients hospitalized for COVID-19 who presented a pulmonary embolism. So the peaks in the frequency of pulmonary embolism corresponded exactly to the 2 COVID waves in France during this year. As I mentioned earlier, we were also able to study the impact of the pandemic on hospitalizations for other diseases. We worked particularly on cardio-neurovascular diseases, diabetes, ophthalmology, cancers, mental and behavioral disorders, and on perinatality. So I show here the impact of the pandemic on hospitalizations for self-harm and alcohol intoxication. Concerning self-harm, you can see in the figure on the left-hand side that hospitalizations in 2020 decreased very sharply compared to 2019 during the first lockdown in the spring period. The figure on the right-hand side is related to alcohol intoxication. You can see in the light blue curve hospitalization in 2019 and in the dark blue curve hospitalizations in 2020. You can see in the red curve the 2 waves of hospitalizations for COVID in 2020. Similarly to self-harm, we found that hospitalization for alcohol intoxication decreased very sharply during the first lockdown, but we also showed that they decreased less markedly during the second lockdown. So we can imagine that mostly during the first lockdown, patients had fear of contracted COVID in hospitals. And surprisingly, this result was even more marked for urgent surgery, such as shown here with a decrease in the number of surgical interventions corresponding to the peak of the pandemic in France as observed before for mental and behavioral disorders. The figure on the left-hand side is related to ophthalmologic surgery. You can see in the green curve hospitalization in 2019, and in the blue curve, hospitalizations in 2020. You can see in the red curve the first wave of hospitalizations for COVID in 2020. And you can see in the right-hand side that similarly to retinal detachment, hospitalizations for carotid artery surgery decreased very sharply during the first lockdown, but we also showed that they decreased less markedly during the second lockdown. And we observed similar results for stroke and myocardial infarction, so other urgent situations, as shown in our publications. So I wanted to discuss a little bit the advantages and limitations of the use of this medico-administrative database. So in my opinion, medico-administrative databases are very useful for providing data at a national level for epidemiological purposes. Sometimes they can be useful also for completing information collected in clinical trials, as they provide real-life data. However, as medico-administrative databases collect observational data, a validation step is crucial. So, as I said before, as these medico-administrative data were collected for budgetary purposes, they may not be reliable for research purposes, and they need to be validated. Networks, such as the national one I set up in France with colleagues in collaboration with national institutions, researchers, and data providers, and conferences, such as the conference I regularly organize with the Association of French-speaking epidemiologists for France, but this conference may be more useful than the conference I organized. All these proposals are very useful. I'm really sorry. I wanted to speak about international comparison based on this data. For example, as shown before, we worked on rehospitalization with Victor Rodwin from the New York University. I also collaborated with Michael Abramovics from McGill University on adverse drug effects. We are currently working with some colleagues at the University of Lausanne on adverse events following hip or knee surgery. I am also involved in a European cost action about childhood abuse, where we try to gather medico-administrative data from different European countries for comparisons. And I wanted to say that these comparisons are quite complicated, as the rules for data collection are not the same in all these countries. For example, most countries fortunately use the international classification for diseases, but the definitions of the main diagnosis and the classifications for procedure may be quite different. So I would like to thank the organizers for this invitation, and I am, of course, I will be very happy to participate in the discussion section. Thank you so much.
Oh, thank you, Catherine, again for another superb presentation. It's really impressive how the data are being used to answer very many important clinical, public health and policy questions. And so I think we will now move to the question and answer component of it, really. So I think at this stage, here we are. We're all up on the screen. The only question I have is the questions. Yeah, I'm not sure I'm seeing the list of questions quite yet. So if I just wanted to start off then while I'm just waiting for those to come through, and ask particularly Majid, I'm very interested in what you've been putting together on an international basis. And I was trying to just get my head around to what extent the studies that you put on that database, if you like, are published surveys versus the real world type data, which Mauricio and Katrin have mentioned. So that was one question. And related to that then is there a relationship with what you're doing on that fantastic work and things like the IHME Global Burden of Disease study?
Sure. So both of them good questions. Let me address the first one because that's actually one that's very, very much on our agenda and our thinking. I think you mentioned published surveys. They don't have to be published. So there are surveys out there that go out and actively sample a population, a community, and we definitely use those. We are increasingly using routine data, and I guess when surveys are as real world. In fact, surveys are arguably more real world because they go and sample the population. So they are there, but we are increasingly using routine data. We are restricting them for the time being, their use to high-income countries, including Central Europe, that have universal health coverage. So we don't use the US routine data because not everybody has access to healthcare. We do use Western Europe, Japan, South Korea, Central Europe, and again, increasingly we are going to go down that route for places like Chile. I think there is actually a very tough question underlying this because even when there is universal health, not everybody sees their GP, for example, and not everybody is measured. On the other hand, survey response rates are increasingly getting getting lower. So in some sense, we are in this tension that which one is less biased? They both have their biases in terms of what population they're catching. And in fact, we were going to drop an email to Catherine after this call or probably the next few days to hear about what the French situation is like. But so I think the answer is we are trying to use routine data exactly because of the advantages that Catherine and Maurizio mentioned. In terms of the parallel to the work at IHME, I started the risk factor component of GBD, so I was involved in that. I think there are a lot of parallels, and I suppose I would say the philosophical parallel is around using as much data as you can, hopefully as high quality data as you can, and synthesizing across this using analytical tools to describe health of populations. I suppose we specialize more. We perhaps spend more time on certain topics, both its epidemiology and its data aspects. We have questions that are not just about level burden. We look at questions of treatment coverage. We look at questions of subgroups of population. It doesn't mean that it can't be done elsewhere. So I think it's a more bespoke and a specialized version versus a more general version. But I think that's a detailed compared to the sort of idea that there are parallel philosophical approaches to them. Again, in terms of something that keeps us really busy right now is the use of routine data, both what we can do with it and access to it. Thanks, Ronan.
Oh, thank you very much. And Mauricio and Katrin, I mean, massively impressive presentations. And this is something I've been involved with for many times. I was the person who wrote the original grant for the SAIL data bank in Wales and doing similar things. But one of the big challenges, which I think both of you brought up, was issues about harmonization and federated analyses, which I think have been a real struggle to the community, rather than replication of sort of running a script in one place and others. Any chance you might have views on how best to improve federated analyses? Or is that too difficult of project to undertake?
Yeah, I can comment on that. Yeah, yes. First, to talk a bit on the question that was put to Majid. Yeah, yeah. I think there is no because you have different type of data. Health is a very complex phenomenon. Yeah, you have different way to collect and to register that. And then this is the first big challenge that we have. Yeah, how to use for the best. Yeah, the data that is available. Yeah, and how this data give supplementary information that the other data do not. Yeah, for example, you have a lot of limitation in routine data because you don't plan the data collection. In the surveys and the research, yeah, you plan your what data you want to collect. And this is a huge difference. Yeah, then there's a difference, but you have advantage on one side and advantage side. What interest is at the end is to understand the problems of the population, the determinants of that. Yeah, how the technologies and the interventions work upon the population. Then these are questions that each strategy of investigation can, yeah, in a complementary way, give important information. Then this is one thing about the federative analysis. Ronan, I think it's a big issue. Yeah, it's a, I think, central issue in my view nowadays. Yeah, because any centralized system of data, yeah, is impossible nowadays. In particular, when you use routine data, there is a lot of barriers, yeah, to data to flow now over the borders. You have Europe. In Europe, you have rules. Yeah, in the United States, in any country, you have rules. Yeah, then I think the big advantage of this idea of the federative analysis is that they develop a strategy to analyze the data, yeah, on different yeah, countries. There is now a lot of efforts to standardize the data. For example, the Odyssey, that is a lot of the developed by pharmacoepidemiologists, yeah, that have accumulate experience, yeah, on this drugs side, yeah, and you have developed this standardization of data. Yeah, this is an important step. Yeah, harmonization of the data and the standardization, and but also a concept. Yeah, that you can do more in a central. There is not a big computer or every single state there. Now, this is a change of mentality, yeah, in terms of data now,
Yeah, that's,
ownership and
thank you.
data process. And this is a point that I would like to
Yeah,
stress.
thank you very much. I very much agree with what you said. I'm just going to bring in Catherine if you get a comment
Yes,
on Catherine.
yes, I completely agree with Najid and Mauricio. It is really difficult to use this data in a collaborative project. For example, well, as I said before, I am currently working with some colleagues in Lausanne, and well, we are working on adverse events following hip or knee surgery. First, we had to obtain the authorizations for example, the French Commission for Data Protection, and the same in Switzerland. Then we had to harmonize the classifications of procedures because they are not the same in the two countries. And then when we obtained the data, well, of course, we had to work in different places because we had to work on the French data in France and on the same in Switzerland. And for example, we are interested in complications, but the rules for the coding in France are not the same as in Switzerland because the impact of the coding of these complications on the budgetary allocation, because you fill in the discharge abstract, and when the physician completes the abstract, he thinks about the implication of his coding
Yeah.
on the hospital budgetary allocation. So we found that some complications were not coded as frequently for example, in one country as in the other. So it was very
Yeah. Oh,
interesting.
thank you very much.
Thank you. I'm
This is
very
a really
sorry.
good.
Yes.
No, sorry. I mean, this is a really good discussion, which I'd love to continue. But I'm looking at the
Yes.
time that we have to get on to
Yes.
the
I'm
other ones.
sorry.
I just would like to thank everybody again. Fantastic presentations. And I think absolutely brilliant opportunities for more collaboration. And one area I'd put in is I'd like to see a lot more collaborations about the evaluation of natural experiments and social policies. Lots of people look at the same problem and have different solutions, and it would be really fascinating to know a bit more about which ones work really the best in that. And with that, I'm just going to close it. Thank you all very much again, and see you at the parallel sessions. Thank you.
Okay.
Thank you.
Thank you.